Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 15th episode of Optometry Series 2.0. I'm very happy to welcome my team members, Miss Meenakshi ma'am and Miss Anshika. Anshika ma'am. Hi ma'am. Thank you so much both of you for joining. Yes, Anshika ma'am, over to you. So your part. So what is today's topic? We very well know that we are doing anatomy and the disease conditions in 2.0 series. So what is today's topic, ma'am, and who's our moderator for the day?
So thanks, Gomati. So today's topic, as we are continuing, we finished so many episodes on the parts of the eye and the diseases. So now we've reached choroid. And today's episode is about anatomy of the choroid. And our moderator for today is Kheerthana. I'm very happy, Kheerthana, that you are with us today. I know her from her days in MN. So I think right now she's currently teaching. She will do a very good job in moderating the session. So without further delay, I would like the MC to please introduce Kheerthana and then we move ahead with the presentation.
Hello everyone, I am Vidyadharshini from C18 batch and I am really glad to welcome you all to today's episode of our Optometry series 2.0. We have a wonderful session lined up and to lead it. We are happy to have with us our moderator Mrs. Kheerthana. Mrs. Kheerthana currently working as Assistant Professor in Optometry School of Allied Health Science, Sri Balaji Vidyapeeth, Puducherry. With over 3 years of academic and clinical experience, her areas of expertise are refraction, binocular vision, contact lens practice, and ocular diagnostics. Ma'am has presented papers at national and international conferences and has a publication of in the TNOA Journal of Ophthalmic Science and Research. She recently won first prize for an e-poster presentation at the 3rd International Health and Research Convention 2025. Please join me in welcoming Mrs. Kheerthana and our speaker for today's episode, Ms. Pavatharani, pursuing her fellowship in clinical optometry at Dr. Agarwal's Eye Hospital. Over to you, Ms. Pavatharani. Thank you.
Thank you, Vidya. Okay, shall I start a screen? Okay, good afternoon to all. So now we are going to learn about anatomy and physiology of choroid and uvea. So what is uvea? The uvea is the middle vascular layer of the eyeball. So located between the sclera and the retina. See, the uvea include iris and ciliary muscles and choroid. It forms the main blood supply of the eye and plays the crucial role in nutrition, light regulation, and immune defense. So choroid. Choroid is posterior most part of the vascular coat of the eyeball. It extends from optic disc to the ora serrata. Its inner surface is smooth and brown. It lies in contact with pigment epithelium of the retina. The outer surface is rough and lies in contact with the sclera. So now we are going to know about microscopic anatomy of the choroid. So it's include three different layers is there. So suprachoroidal lamina, a thin membrane of contains the collagen fibers and melanocytes and fibroblasts. So continues anteriorly with the supraciliary lamina, and also the suprachoroidal space contains a long and short posterior ciliary arteries and ciliary nerves. And second one is stroma of the choroid, composed of loose collagen tissue. with elastic and reticulum fibers. It contains pigment cells and plasma cells. The main bulk consists of blood vessels arranged in three layers. Its first one is callus layer. It is the outer layer of large vessels, and Saddler's layer is a middle layer of medium-sized vessels. The choriocapillaris is innermost layer and resists the outer retina. So third one is the basal lamina. Also, it's called as a breast membrane. Lies internal to the choriocapillaris. Choriocapillaris, it close to contact with the 1 minute. Contact with the retinal pigment epithelium. So the picture indicates the microscopic structure of the choroid. The blue one is sclera, and the followed by the layers of choroidal, and last one is pigment epithelium. So macroscopic anatomy of the choroid is posterior vascular part of the uveal tract. The macroscopic anatomy and thickness of choroid is approximately 0.22 mm posteriorly near optic disc, and approximate 0.1 mm anteriorly near ora serrata. One minute. So appears dark brown and black due to abundant melanocytes, which is prevent light scatter. So next, ciliary process of the choroid. The ciliary process of the choroid, finger-like projections from the pars plicata portion of the ciliary body, and the approximately 70 to 80 process it's seen. Dimensions is approximately 2 mm long and 0.5 mm in diameter. The color of ciliary process is white. The structure of ciliary process is each process has a core of loose connective tissue containing blood vessels and covered by two layers of epithelial cells. And the function is primarily site of aqueous humor protection. So, choroid functions is nutrition of outer retina. It supplies RPE plus photoreceptors via choriocapillaris. The second one is light absorption. Melanin in choroid absorbs stray light and improving image quality and visual acuity. The third is thermoregulation. Rich choroidal blood flow helps into heat dissipation from the metabolically active retina. So, blood supply of uveal tract is arterial supply. The uveal tract, it includes iris, ciliary body, and choroid, is supplied by three sets of arteries. The first one is short posterior ciliary arteries. It arises to two trunks from the ophthalmic artery. Each trunk divides into 10 to 20 branches. So, these pierce the sclera around the optic nerve and supply the choroid in a segmental pattern. The second one is long posterior ciliary arteries. This is nasal and temporal and pierce the sclera obliquely on either side of the optic nerve. Travel forward in the suprachoroidal space to the ciliary muscle without giving branches. And anteriorly, they anastomose with each other and with anterior ciliary arteries to form branches that supply the ciliary body. And third one is anterior ciliary arteries. It derived from muscular branches of the ophthalmic artery. Also, it's seven ciliary arteries is there. So two from superior rectus, and two from inferior rectus, and two from medial rectus, one from lateral rectus. The pathway of anterior ciliary arteries is run anteriorly in the episclera, give branches to sclera, limbus, and conjunctiva, pierce sclera near the limbus to reach the ciliary muscles. So, venous drainage, veins from the iris, ciliary body, and choroid unite to form vertex veins. These pierce the sclera behind the equator and drain into superior and inferior ophthalmic veins, which finally drain into the cavernous sinus. So now we are going to learn congenital and developmental abnormalities of choroid. The first one is choroidal coloboma, a congenital defect due to failure of closure of the embryonic fissure during the 5th to 7th week of gestation is choroidal coloboma. And the site of choroidal coloboma is commonly located infranationally in the fundus. The appearance of choroidal coloboma is white, sharply demarcated area of absent retina and RPE and choroidal exposing the underlying sclera, may be oval or round in shape. Association is iris coloboma and optic disc coloboma, microphthalmus. And the systemic association is Charge syndrome. The visual prognosis is depends on macular or optic disc involvement. So this is choroidal coloboma. The picture is indicate choroidal coloboma. Here it's seen. Next, we are going to choroidal hypoplasia. The choroidal hypoplasia is underdevelopment of the choroid due to incomplete differentiation or vascular development. And the etiology of choroidal hypoplasia is it's congenital, genetic, or developmental. May be associated with oculocutaneous albinism or optic nerve hypoplasia. And the clinical features of choroidal hypoplasia is pale fundus appearance and reduced pigmentation of RPE and choroid, and also may be associated with reduced visual acuity or nystagmus. Okay. Next is choroidal hemangioma or congenital vascular hematoma. What is choroidal hemangioma? Is a benign vascular tumor of the choroid present at birth or early childhood. This is also two types. Is there? One is circumscribed, localized is solitary lesion, and diffuse is involves large area often associated with Sturge and Weber syndrome. In choroidal hemangioma is appearance orange red elevated mass usually posterior to the equator and may cause serous retinal detachment. The symptoms of choroidal hemangioma is blurred vision due to macular involvement or secondary exudation. So the picture is indicate choroidal hemangioma. So here we can see. Okay. So congenital hypertrophy of retinal pigment epithelium. So what is congenital hypertrophy of retinal pigment epithelium? Is focal area of RPE hypertrophy and hyperpigmentation, often with underlying choroidal thinning. And features of congenital hypertrophy of retinal pigment epithelium is round or oval flat lesion with dark pigmentation and sharp margins. May have depigmentated lacuine within. Association of CHRP is multiple lesions may indicate familial adenomatous polyposis. So, in the picture is indicate CHRPE and choroidal ossification. It's rare condition. So abnormal bone formation within the choroid may be congenital or acquired. Etiology of choroidal ossification is rarely it's congenital, often secondary to long-standing inflammation, trauma, and or detachment. Appearance of choroidal ossification is yellow, white flag or slightly elevated plaque near a equator, detected on B scan or OCT as a calcified reflective mass. So, choroidal nevus. Definition. Choroidal nevus is benign congenital accumulation of melanocytes within the choroid. Appearance of choroidal nevus is slate gray or black flat lesion with distinct or fusy borders, usually found in the posterior fold. So, signification of a choroidal nevus generally stable and asymptomatic. Requires observation to rule out malignant transformation. So here we can see choroidal nevus and acute disease of the choroid. There is five categories is there. So first one is inflammatory and second one is degenerative and third one is vascular and fourth is neoplastic and fifth is traumatic. So first inflammatory category. There is a four conditions is there. First one is choroiditis. Choroiditis caused by infection or autoimmune disorder. The clinical appearance is yellow white patches with insistent margins and the symptoms is blurred vision and floaters photopsia. And second one is chorioretinitis, the caused by inflammation involving both retina and choroid. The clinical appearance is grayish white lesion, and the symptoms of chorioretinitis is decreased vision and scotoma. And tuberculosis choroiditis caused by hematogenous spread of mycobacterium tuberculosis. The clinical appearance is multiple yellowish nodules near posterior pole, and the symptom is often with systemic TB. And syphilitic choroiditis is caused by Treponema pallidum infection, and the clinical appearance is salt and pepper fundus in congenital form. The symptoms of blood vision. So first picture is indicate a healed patch of central chorioretinitis, and the second one is yellow-white nodal, yellow-white patches in margins, and third one is grayish-white nodules. And second category is degenerative. There is a three conditions is there. The first one is senile choroidal atrophy. It's caused by age-related thinning of choroid and RPE. The clinical appearance is pale fundus with visible large choroidal vessels, and the symptoms is usually asymptomatic. And myopic choroidal, second one is myopic choroidal degeneration. So it's caused by progressive axial elongations and choroidal and RP atrophy. The clinical appearance is posterior staphyloma, lacunar cracks, and future spots, and the symptoms is gradual visual loss. And the third one is anginoid sticks. It's caused by breaks in brush membrane, and clinical appearance is reddish brown irregular illness radiating from optic disc. The symptoms is often bilateral. So the picture is indicate myopic choroid. One minute. Okay. The third category is vascular. So there is a two conditions is there. One is CNVM, it's also called as choroidal neovascular membrane, and caused by new vessels from choriocapillaries breaching breast membrane. And clinical appearance is subretinal grayish green membrane, hemorrhage, exudation, and symptoms is distorted vision and metamorphopsia. And second one is CSR. It's caused by increased vascular permeability, and clinical appearance is dome-shaped elevation of retina and choroid. The symptoms of CSR is blurred vision and metamorphopsia. And fourth category is neoplastic. There is a three conditions is there. One is choroidal melanoma, the caused by malignant proliferation of choroidal melanocytes. The clinical appearance of choroidal melanoma is dome or mushroom shaped brownish mass. The symptoms of choroidal melanoma is visual field defect and floaters. And the choroidal metastasis, it's caused by secondary spread from breast or lung carcinoma, and clinical appearance is creamy yellow platinum shaped lesion, and the symptoms is blurred vision and pain. The choroidal hemangioma is the third condition, and the caused by vascular hematoma, and clinical appearance is orange red mass may cause subretinal fluid. The symptoms is blurred vision and metamorphopsia. So here CNVM is seen, and the picture is indicated CSR. So this is choroidal melanoma. The fifth category is traumatic or miscellaneous, and the three conditions is there. So first is choroidal rupture. It's caused by blunt ocular trauma and tear in branches membrane. The clinical appearance is curved crescent near optic disc and concentric to it. The symptoms is sudden vision loss. So second condition is choroidal effusion or detachment. It's caused by exudation or hemorrhage between choroid and sclera. So the clinical appearance is smooth and dome-shaped elevation of choroid. The symptoms is pain and blurred vision. So third condition is a choroidal hemorrhage. So the caused by rupture of choroidal vessels. Clinical appearance is dark elevated choroidal mass. Symptoms is pain, loss of vision. So investigations. There is a six investigations is there. So first one is fundus examination FFA. So evaluates retinal and choroidal circulation, identifies leakage, ischemia or CNVM. And the second one is OCT, cross-sectional imaging to assess choroidal thickness and CNVM detachment or edema. And third one is B scan ultrasonography for detecting choroidal tumors and hemorrhage or detachment when media or opaque. So fourth one is visual field testing, like perimetry, detects scotomas and peripheral field loss due to choroidal lesions. The fifth one is laboratory test, identify underlying infectious or inflammatory causes. And fifth one is PCR testing of aqueous vitreous, detects microbial DNA in infectious choroiditis. And the final is CT and MRI orbit, assess intraocular tumors and extract of invasion or metastasis. So, to conclude, a multidisciplinary approach addressing both ocular and systemic causes ensures better visual prognosis and long term disease control. Thank you all.
Thank you so much, Pavatharani. It was an elaborative presentation on the anatomy, physiological part, and the disease. To the extent you have covered the major diseases affecting the choroid. And now I request our moderator, ma'am, to add your valuable clinical inputs, ma'am.
Thank you, ma'am. First of all, good afternoon to all. And I would like to thank Mrs. Anshika, ma'am, and other faculty members for inviting me to this wonderful session. And also, Ms. Pavatharni did a beautiful and detailed presentation. So I will now briefly highlight the anatomical features of the choroid, which is essential part of the uveal tract. So first, as she said, choroid is the posterior vascular layer of uvea lying between the sclera and retina, extending from optic disc to ora serrata. So it is a dark brown in color due to the abundant melanocyte that absorb stray light and prevent the image blur. So structurally, as we see microscopically, it has three layers: suprachoroidal lamina, second layer vascular stroma, which comprises of hallus, satellus, and choriocapillaris layers, and third is Bruch membrane, which is adjoined to the retinal pigmented epithelium. So it will provide oxygen and nutrient supply to outer retina and maintains the retinal metabolism. So the choroid can slightly change its thickness according to the adjustment of the focusing of the eye, which we termed as emetropization. So this helps eyes to maintain the clear vision and proper growth in younger stage. So additionally, the choroid helps in thermoregulation, that is the dense vascular network allows heat disruption from the highly active retina. So as we know, nerve supply of choroid is long and short ciliary nerve and venous drainage. So venous blood from choroid drains to the eye four vortex veins. So that vein is pierced the
Ma'am,
scleral.
sorry to disturb. Yeah, your
Yes,
paper
ma'am.
was obstructing the video, ma'am.
Okay, ma'am. Now, ma'am, it's clear, ma'am.
Yeah, it's fine now, ma'am.
Okay, ma'am. So, as we know, venous drainage, venous blood from the choroid drains through four vertex veins. So, the vein pierces the sclera between the equator and empty the ophthalmic veins, which drains into the cavernous sinus. So, lastly, blood supply, it receives the blood from the branches of ophthalmic artery, that is short posterior ciliary artery and long ciliary posterior artery. So, these are the overbrief of the anatomy of the choroid. So it is also clinically important because many diseases such as choroiditis, choroidal neovascular membranes, and tumor originates from the specific choroidal layers as she mentioned in the presentation. So additionally, I would like to tell the clinical points which are relevant to the anatomical structure of choroid. So first, choriocapillaries, if we take, so it is an innermost vascular layer which supplies oxygen and nutrients to the RPE and photoreceptor. So in case if it get damaged, it causes the outer retinal degeneration. As we said, it can be determined in the investigation. So second, Bruch membrane. It is a thin basal lamina between the choroid and RPE, and it acts as a metabolic exchange barrier. So if this layer get thickens, it leads to drusen formation and early macular degeneration. As we know, age-related macular degeneration is a most important disease condition. So it can be identified early in case if the disease condition is progressive. Third, Halley's and Sattler's layers. So as I said before, these vascular layers are often visualized in OCT. So it shows whether the blood vessels are in dilatation state or congestion, which is will be seen in condition like central serous chorioretinopathy, etc. Fourth is suprachoroidal space. So this potential space between sclera and choroid is important clinically for suprachoroidal hemorrhage, effusion, and targeted the drug delivery in the posterior segment. And next, vortex veins. The choroid drains through the four vortex veins. So in this condition, if any blockages happen or detachment is seen, we can detect it earlier in case of any trauma or venous pressure condition. So the position of vortex vein serves as a key landmark during the scleral buckling procedure and also for the posterior segment surgery diseases condition. And next is melanocyte or tumor. So because the choroid is rich in melanocyte, it is the common site for choroidal melanoma and nevus. So fundus pigmented pattern corresponds to this anatomical position. And next, segmental arterial supply. The short posterior ciliary arteries supply the choroid in segments. So if any occlusion of a branch causes localized ischemic lesion matching the vascular territory. Next one is choroidal thickness. The anatomical thickness vary with the ocular location, that is thinner at the anterior and thicker at posterior. Clinically, this thickness can be measured in OCT. So in disease condition like myopia or uveitis, etc. And last one is high blood flow. The choroid has one of the highest blood flow per time per volume. So it is also essential for the retinal metabolism and thermal control relevant for the laser treatment, if any, we can take this condition.
Thank you so much, ma'am. It was a clear, crisp add-ons for the narrative and anatomical part of your our topic today. From the student's perspective, we do have certain questions to be asked for, ma'am. Shall I read it for you, ma'am?
Yes, ma'am.
First question is, how do Sattler's and Haller's layer differ functionally?
So as I said, these are the vascular layers, so mostly rich in blood supply. So maximum if in any disease condition, as I said in central serous retinopathy or any other condition, veins and arteries plays a major role. So that dilatation and any congestion can be determined in this layer, and we can able to find the disease which can cause whether which condition due to Hallis or Sattler's layer.
Thank you so much, ma'am. The next question is, what systemic diseases commonly affects choroid?
So common diseases like ARMD, even though the drusen formation, mild cases, detachment, uh, ischemic conditions, tumor conditions that affect the choroid will determine upon the stages, like what stage it occur, we can able to investigate and we can do treatment based on that.
Thank you so much, ma'am. And the last question is, as you described the thermal regulations of your choriocapillaries, students have asked, how is it actually helping the thermal regulations in retina?
So as I said, it is actually a dense vascular network. So due to that, the heat, due to that, the retina will be in active state, and that causes that photothermal action due to that dense vascular supply of blood supply.
Thank you so much, ma'am. That's all the questions from our student side. If there is any more questions, we'll let you know, ma'am.
Sure, ma'am.
Anshi, ma'am, are you there, ma'am? Any questions to our moderator, ma'am?
No, I don't have any questions. I think though choroid, if we look at it is as a very small part, but then there are a lot of diseases which we should really not forget while we are looking at a patient and trying to diagnose. So thanks, Kheerthana, for actually bringing out all the anatomical parts. I think you prepared notes and you were reading out and you were explaining. So it was really good for students to collaborate together. Very good presentation, Pavatharani, where you had the tables and when you explained about the degenerations and all those things. So I think both Pavatharani and Kheerthana together really made choroid anatomy very interesting. Thank you to both of you. Over to you, Gomati.
Thank you, ma'am.
Thank you, ma'am.
Yes. So thank you so much, Anshika ma'am. Thank you, Meenakshi ma'am, Anshika ma'am, for joining with us today. And Kheerthana ma'am, thank you so much for joining us as the moderator for the day. We'd like to host you on another wonderful platform, ma'am.
Thank you, ma'am.
Thank you, Pavatharani, for the presentation. It's an excellent presentation. Best wishes for your future. Dear audience, thank you all for your continuous support towards Optometry series. The announcement for this particular week is it's exam season at Dr. Agarwal's Institute of Optometry. All the very best from the management side to all the students who's taking examinations at our institute and others who's taking their optometry examinations at every other places. So all the very best. The next announcement for this particular week is the admissions are open for fellowship courses and pan in the internship at Dr. Agarwal's Institute of Optometry. The course details, the contact details, everything will be given in the description box. If you like this video, give a thumbs up and share with all your friends. We'll meet you in the next episode. Thank you all so much for joining. Thank you. Thank you, Kheerthana ma'am. Bye, ma'am.
Thank you. Thank you.